Welcome back to the deep dive. Today, we aren't just, flipping through flashcards. We're really getting into the high-stakes stuff in orthopedic reconstruction.
Right.
Our deep dive today goes beyond the simple fracture. We're looking at the anatomy of extremes, really. Moving from getting that perfect alignment in a primary joint replacement all the way to handling, well, catastrophic bone loss and some pretty disastrous infections.
Yeah.
This is basically our fast-track review of the critical moments, the decisions that really define what we do in practice.
That's a perfect way to put it. We're really looking at the surgical limits, aren't we? That point where we have to decide if we can rebuild or if we need to pivot towards limb salvage or maybe even amputation as the best option.
Exactly.
We'll be focusing in on knee, ankle, and shoulder reconstruction, the thinking behind limb removal, and, crucially, that relentless fight against musculoskeletal infection, osteomyelitis, and septic arthritis. I mean, this stuff, these specific numbers and techniques, they really dictate how well things look 5-10 years down the line.
And our mission for you, listening in, is not just to hear a list of facts, but to really get the why behind them. We want you to grasp the synthesis, the exact targets, the steps, the complex algorithms that guide us in these high volume or really complex cases. So let's start where mechanical precision is absolutely king, total knee arthroplasty, TKA.
Okay, so TKA. When you approach the femoral side, it feels like we're juggling geometry and biology, right? What's the absolute basic requirement for prepping that distal femur? And how does choosing to keep or sacrifice the PCL change how we cut the bone?
Well, the fundamental thing is creating the right shape, the right box for the implant. So no matter what you do with the PCL, you have to make that distal femoral cut first. That sets your mechanical axis.
Got it.
Then you need those chamfer cuts, anterior and posterior, to shape the bone so the femoral component fits snugly. The real fork in the road, surgically speaking, is the PCL, like you said. If we go with a PCL retaining design...
Like keep the ligament.
Exactly. We make those basic cuts, and that's it. We rely on the patient's own ligament for stability, for that rollback inflection. But what if the PCL is shot? Or we just decide, for this patient, it's better to take it out.
Then we step into the PCL substituting world. And that means we have to provide that stability mechanically, usually with a post and cam mechanism built into the implant.
Right, the little post that fits into a box.
Precisely. And to make room for that mechanism, we have to do an extra, very specific bone cut right in the intercondylar notch. We're basically creating a little garage or box for that cam to engage with the polypost. It stops the knee from sliding backwards.
So that extra box cut, that's the key difference. It really commits you to that implant design.
It absolutely does. It's a defining technical step. Removes a bit more bone, adds complexity.
Okay, moving down to the tibia. We know the cut needs to be perpendicular to the mechanical axis, but getting that posterior slope just right, it always feels a bit like trying to level a foundation on a slightly, tilted surface. What's the target slope, and how do the implants help us hit it?
Yeah, that's a good analogy. That slope is crucial for knee kinematics, especially flexion. We generally aim for some posterior slope. Now, many modern systems, they actually build 3 degrees of posterior slope right into the polyethylene insert itself.
So it's built in, like a bit of a cheat code.
Sort of, yeah. It's clever engineering. It means even if your cutting block is off by a hair, the implant itself helps provide that critical slope. It takes some pressure off the surgeon needing absolute perfection with the saw. The implant helps control the alignment.
The implant making up for maybe slight imperfections in the cut. I like that. Then there's the question of how much bone to take. Resection depth. This is where you really need to know where you're measuring from, isn't it?
Oh, absolutely critical. The resection amount determines your joint line. Get that wrong, and ligament tension is off, patellar tracking is off. It's a mess. So if you reference the undefected side, say in a valgus knee where the lateral side is relatively okay.
You measure from the good side?
Right. You typically aim to take off about the thickness of the implant components, which is usually around 8 to 10 millimeters.
Makes sense. You're basically recreating the joint line before the arthritis wore it down.
Exactly. But now flip it. If you're referencing the most arthritic side, the worn down, collapsed side may be in a varus knee.
The bad side.
Yeah. Then you have to be much more conservative. You're aiming for a minimal cut, often 2 millimeters or less. This is vital to avoid taking too much bone and raising the joint line. Raise it too much and the knee gets stiff, function is poor. Knowing that difference, 10 millimeter versus 2 millimeter, based on your reference, that's fundamental. That's fundamental. Get it wrong. And the knee could be unstable or way too tight from the start.
Okay, bone cuts are done, trial components are in. Now the dynamic part, gap balancing. What's the geometric target here? What are we trying to achieve?
Perfect symmetry. The goal is to get what we call a rectangular flexion gap. That means the space between the femur and tibia is exactly the same, medially and laterally, and it's under the right amount of tension, both when the knee is straight in extension and when it's bent to 90 degrees in flexion. We use special tools like spacer blocks or tensioners to measure this.
And let's say you measure and the gaps are equal medial and lateral, but they're both just too loose. The whole thing feels sloppy.
Right, the windshield wiper effect, we sometimes call it. If the gaps are equal but lax, it means your ligaments are effectively too long for the space you've created. The fix here is actually pretty straightforward. You can't just cut more bone that would make it worse.
Right.
You simply need to fill the space. You upsize the components, use a thicker tibial polyethylene insert. This increases the overall size of the implant system, tensions those collateral ligaments, and restores stability without messing up your joint line.
Makes sense. Fill the gap. Now what about technology? Computer-assisted alignment, or CAA. Sounds amazing objective data, fewer outliers. Has this tech basically taken over primary TKA?
You'd think so, wouldn't you? But surprisingly, no. CAA hasn't seen huge adoption for routine primary knees across the board.
Really? Why not?
Well, the data is clear on one thing. Imageless navigation systems do give better data. They demonstrably decrease the number of alignment outliers, especially in the coronal plane, that vas valgus alignment. So technically, the implant position is often better. That's quantifiable.
But then comes the million-dollar question. Does that technical perfection actually make the patient feel better or function better? There was that big meta-analysis.
Right, exactly. That's the crux of the debate. That meta-analysis, pooling data from 22 studies, found that while navigation led to better alignment on X-ray, there was no significant improvement in functional outcomes overall, at least not in the short to medium term. Patients weren't reporting less pain or better motion on average.
So better X-rays, but patients felt the same.
Pretty much, in the shorter term. However, we have to look at the long game. There was a big prospective study that followed patients for longer. And that study found that at the 5-year follow-up, the Knee Society scores, a measure of pain and function, were actually significantly higher in the group that had navigation.
Ah, okay. So maybe the benefit isn't immediate, but it shows up later. The idea being that better alignment prevents subtle wear and tear down the road.
That seems to be the thinking. A tiny bit of malalignment might not hurt much at 1 year, but 5 years of uneven loading. That could lead to polyethylene wear, maybe some loosening ligament issues. It suggests that technical perfection, getting that alignment spot on with navigation, might really pay off in terms of implant survival and long-term function, which, is ultimately what we want in arthroplasty, a joint that lasts.
That actually leads us perfectly from the primary goal of perfection into the, let's say, messier side, revision surgery, where bone loss is almost inevitable. Before we even think about fixing it, we have to classify the defect. What are the first 2 big categories we need to distinguish between? The ones that immediately change our plan.
Right. The very first thing you assess is whether the defect is contained or cavitary versus non-contained or segmental. Think of contained defects like potholes in a road, there's a hole, but the surrounding pavement, the cortical rim, is intact.
Okay, walls are still there.
Exactly. They're usually easier to deal with because you can just fill them. Now, non-contained or segmental defects, those are much tougher. They're like the edge of the road crumbling away. They lack that solid, bony rim, often extending right out to the edge, the cortex. You can't just pack stuff in. You need to provide structural support, maybe even replace a whole chunk of bone.
And for communicating this, we use formal systems, right? Like the RAND classification or the AORI system.
Yeah, we need a common language. The RAND classification is older, simpler. Type I is small metaphyseal loss. Type 2 is bigger metaphyseal loss, but both are contained within bone walls. Type 3 is the worst, involves both the metaphysis and the cortex, usually meaning a non-contained defect.
Okay, and the AORI system.
The Anderson Orthopedic Research Institute, AORI system, is more detailed, kind of the modern standard. It classifies defects on both the femur, F1 to F3, and the tibia, T1 to T3. A key distinction, especially for planning, is within the Type 2 defects. Type 2A means bone loss is just on one side, one condyle or plateau, but a Type 2B involves both condyles or both tibial plateaus. That's a much bigger reconstructive challenge.
So let's say you, the listener, are looking at scans for revision and you see a T2B tibial defect. What specific feature tells you, okay, forget just using cement, we need a structural graft or maybe a metal augment?
The big indicators are the size and the location, especially if it compromises where the implant needs to sit securely. If you've got that T to B, both sides of the tibia involved, and the hole after you clean it out is deeper than, say, 5 millimeters, Or if you've lost more than half the surface area of the tibial plateau, well, cement alone isn't going to cut it. It won't be stable.
Right.
Small defects under 5 millimeter. Yeah, cement or maybe some bone graft substitute works fine. If it's contained, even if it's bigger, packing it tightly with cancellous bone graft is often the best it incorporates over time. But those big non-contained defects, that's when you need metal wedges or cones or maybe modular stems that bypass the defect entirely. In the really bad cases, a structural allograft, like a piece of donor bone, might be necessary.
Okay, shifting gears slightly, but still in the realm of TKA problems, the patellofemoral joint. Complications here can really wreck an otherwise good knee replacement. What are the usual suspects when the kneecap starts tracking poorly or causing pain?
Patellofemoral issues almost always boil down to mechanics, an imbalance in the forces. The most common culprits are either a tight lateral retinaculum, the tissue on the outside pulling the kneecap over, or, conversely, loose soft tissues on the medial side.
So it's a tug of war gone wrong.
Pretty much. And you have to think about the geometry. If you try too hard to center the patellar button during surgery, you can actually increase the Q angle, that angle between the quad muscle pull and the patellar tendon. A higher Q angle inherently makes the patella want to slide laterally, increasing instability risk.
And the size of the knee components themselves matters too, right?
Huge factor. If the femoral component is too big front to back, or if you didn't resect enough bone off the back of the patella, the whole extensor mechanism gets pushed too far forward.
Overstuffed.
Exactly, overstuffed. This increases tension, makes bending the knee hard, causes pain, and can definitely lead to subluxation or instability. It's a really fine balance in 3 dimensions.
And then the real disaster, a patellar fracture after TKA. How common is that and what usually causes it?
Thankfully, it's pretty rare, happens in less than 1% of TKAs. But when it does happen, it's strongly linked to a couple of things. One is technical error, taking off way too much bone from the patella, just making it too thin and weak.
Okay.
The other, and this has a statistically significant link, is vascular compromise. If a lateral release is done cutting that tight lateral tissue and it's done too aggressively, you can damage the blood supply to the patella, specifically the superior lateral genicular artery. If that vessel's knocked out, the bone can die, leading to osteonecrosis and then fracture, even under normal loads.
Wow. So even a common step like a lateral release has potential downsides if not done carefully. Okay, let's travel down the leg to the ankle. Here we have that classic debate, total ankle arthroplasty, TAA, versus ankle fusion, or arthrodesis. Fusion was the gold standard forever. Why are we seeing more TAA now, even though it's arguably more complex?
Well, arthrodesis is reliable, definitely gets rid of the ankle pain. But the downside is by locking the ankle, you transfer all that stress to the joints next door, mainly the subtalar joint below it, and even up to the knee and hip. This often leads to arthritis in those adjacent joints down the line.
Right. The next joint in the chain takes the hit.
Exactly. TAA, on the other hand, preserves motion. And with the newer generations of implants, the results are getting better. Patients often report better function, higher satisfaction, especially for things like walking on uneven ground. Keeping that up and down motion is really helpful for daily activities.
When we look at TAA implants, we see 2 main types, fixed bearing and mobile bearing. What's the core idea differentiating those two?
It really comes down to how forgiving they are of tiny alignment errors. In a fixed bearing design, the plastic part, the polyethylene, is locked rigidly into the metal tibial tray. If your alignment isn't absolutely perfect, you can get high stress on the edges of the plastic, leading to faster wear.
Edge loading.
Right. Now, the mobile bearing design has a polyethylene piece that can rotate and slide a little bit between the metal components. Think of it like a floating disc. The theory is that this mobility allows the plastic to adjust slightly, to find the position of lowest stress, even if the surgeon's alignment wasn't 100% perfect. It's meant to be more forgiving.
That forgiveness sounds good in theory. Does it actually translate? Do mobile bearing ankles lead to better walking than fusion?
The data is a bit mixed, actually. General gait analysis, comparing TAA to fusion, often shows conflicting results. However, some studies do specifically show that TAA patients walk better on uneven surfaces compared to fused ankles. That makes intuitive sense. Having even a little bit of motion helps you adapt to slopes or bumps.
Okay, but here comes the big but, the red flag with TAA that we absolutely have to talk about. Even if function feels better to the patient, the complication rates, they look pretty scary compared to fusion, based on studies like Daniels and Krauss's work.
This is the really tough part of the conversation with patients. You're right. TAA has a significantly higher rate of needing more surgery reoperations and major complications. Some studies report rates as high as 54% for TAA needing further intervention, compared to maybe 26% for ankle fusion.
Wow, that's more than double the risk of going back to the OR.
It is. So for us, and for you listening, this means TAA is kind of a high-reward, high-risk procedure. The reward is motion, potentially better function on uneven ground. The risk is a much higher chance of problems down the road, loosening, wear, cysts, needing revision surgery. This forces us to be really careful with patient selection. Often TAA is better suited for older, lower-demand patients, or maybe people who already have stiffness in other joints in that same leg, where preserving ankle motion is extra important. We have to be brutally honest with patients about these risks.
Okay, let's move up the body to the shoulder. Total shoulder arthroplasty, TSA. Like the knee, getting the anatomy just right is paramount. If we don't rebuild that proximal humerus geometry correctly, the whole thing can fail. What are the key anatomical numbers we have to hit?
There are three big ones we absolutely focus on. First, the neck shaft angle of the humerus. On average, it's about 45 degrees, but there's a bit of a range. Say 30 to 50 degrees is usually acceptable.
Okay, 45 degrees.
Second, and this is often tricky, is the offset. The humeral head isn't centered perfectly on the shaft. It's offset slightly. Typically, it sits about 2.6 millimeters posterior and 6.9 millimeters medial to the center line of the humeral shaft.
Why is getting that offset so vital? It seems like a small detail, but I guess it matters hugely, like putting a door hinge slightly off.
That's a great analogy. If you get the offset wrong, particularly if you make the head too prominent or too far lateral, you basically overstuff the joint.
Too tight.
Exactly. It limits rotation, jams the components together, causes pain, and the patient just can't move their arm properly. Third key metric is version, or rotation. Especially in a reverse TSA, we aim to put the humeral stem in about 20 to 30 degrees of retroversion relative to how the elbow bends. Getting that rotation right helps optimize the range of motion and stops the components from clunking together anteriorly.
You mentioned reverse TSA. That's usually for patients with massive, irreparable rotator cuff tears, right? Which brings us to that classic failure mode of a standard anatomical TSA in someone with a bad cuff. The rocking horse effect. What's happening there?
The rocking horse effect is precisely why the reverse shoulder was invented. In a shoulder where the rotator cuff is gone, especially the supraspinatus, there's nothing holding the humeral head down in the socket.
Yep.
So when the deltoid fires to lift the arm, the humeral component just rides upwards superiorly.
Okay.
This means the force isn't going nicely through the center of the glenoid socket anymore. It's loading eccentrically, right on the top edge. Over time, this repetitive upward levering, this rocking motion on the superior rim, it just pries the glenoid component loose. It's almost guaranteed to fail from eccentric loading.
A mechanical death sentence, basically.
Pretty much.
And the reverse TSA solves this by, well, reversing the ball and socket.
Exactly. We put the ball on the shoulder blade side, the glenoid, and the socket on the humerus. This does two crucial things. It moves the center of rotation lower down and more towards the midline. This change dramatically increases the lever arm for the deltoid muscle, making it a much more efficient elevator of the arm, even without a functioning rotator cuff.
Clever.
And the newer designs, especially what we call lateralized constructs, push the socket part on the humerus a bit further out laterally. This helps in a couple of ways. It can improve the function of any remaining rotator cuff muscle, like the teres minor, and very importantly, it significantly reduces the rates of scapular notching.
Scapular notching, what's that?
That's when the plastic liner on the humeral side bangs against the bottom edge of the scapula, the shoulder blade, during arm movement. It can wear down the plastic in the bone, create debris, and lead to failure. Lateralizing the design pulls the humerus away from the scapula, giving it more clearance and reducing that notching risk.
Makes sense. Okay, let's shift just distal to the elbow. Total elbow arthroplasty, or TEA. We've seen designs evolve from those really rigid, constrained hinges to the modern semi-constrained ones. What's the core difference in how they handle stress?
The early designs, like the McKee or the Stanmore, were true hinges, very constrained. They linked the humerus and ulna rigidly. The problem was they transferred all the forces bending side to side, valgus vars, twisting rotation directly through that middle hinge and into the bone where the stems were cemented. This led to really high rates of loosening because the bone cement interface just couldn't handle that constant stress.
Right.
The modern semi-constrained designs are smarter. They allow a little bit of wiggle room, a few degrees of valgus versa movement, a bit of rotation. This built-in slop, if you will, allows those stresses to be dissipated, partly through the implant's linkage, but also shared with the surrounding soft tissues, the ligaments and capsule. It doesn't funnel everything straight to the bone cement interface. That dissipation is key to their better long-term survival.
And what about for patients with, say, severe rheumatoid arthritis? They often have terrible bone quality. Are there other options?
Yeah, for some low-demand rheumatoid patients, sometimes unconstrained resurfacing type arthroplasties are used. These basically just cap the joint surfaces without linking them together. The results can actually be pretty good in that specific population, maybe 85% satisfactory outcomes reported.
Hmm.
But we have to be clear, when any TEA fails and you're going back for a revision, that's a major salvage operation. The risks go way up.
Because of scarring, bone loss, and nerve proximity. I remember hearing the radial nerve is really close when taking out the humeral stem.
Dangerously close. The radial nerve wraps right around the back of the humerus. When you're trying to get a well-fixed humeral component out, especially dealing with scar tissue and cement, that nerve is very vulnerable. You absolutely must find it and protect it during the exposure for revision TEA. It's non-negotiable.
And then there's the patient counseling side, which sounds really tough after a revision TEA. You give them a working elbow, but then you have to tell them, don't use it much.
That's the hard reality. Even with modern semi-constrained designs, the mechanical forces across that elbow hinge are immense. To maximize the lifespan of the implant and minimize the risk of it breaking or loosening again, patients need strict, lifelong activity restrictions. We typically tell them they must avoid lifting anything heavier than 10 pounds, maybe 5 kilograms permanently.
10 pounds? That's like a gallon of milk, maybe a small bag of groceries.
Exactly. It's a significant limitation. We know patients often exceed it, but that strict limit is there because higher, repetitive loads dramatically increase the stress on the polyethylene bushing, the hinge mechanism, and the stem fixation. It's a trade-off. We give them pain relief and motion, but they lose strength and have to accept those restrictions for the implant to hopefully last.
Sometimes, though, even the most complex reconstruction isn't the right answer. We have to pivot to amputation. And it's crucial, isn't it, to frame this not as a failure, but as a constructive step.
Absolutely essential. That mindset shift is key for both the surgical team and the patient. Amputation shouldn't be seen as giving up. It needs to be presented honestly as the first step towards a comfortable, functional, and productive life, especially when compared to living with a chronically painful, infected, or non-functional limb. A well-performed amputation followed by good prosthetic fitting can offer far better quality of life and mobility. Getting there early is often better than multiple failed salvage attempts.
And when deciding where to amputate in the leg, the single biggest factor seems to be the functional cost, specifically energy expenditure. The difference between below knee and above knee is just huge.
It's staggering, and it dictates everything about prosthetic use later. A patient with a good transtibial amputation below the knee requires about 40% to 50% more energy to walk with a prosthesis compared to someone with two legs. That's significant, but manageable for many.
Okay, 40–50% increase, but above the knee.
If you move up to a transfemoral amputation above the knee, the energy cost skyrockets. We're talking a 90% to 100% increase in energy expenditure just to walk at a normal pace.
Doubling the effort just to walk? No wonder prosthetic use drops off so much at the transfemoral level.
Precisely. It becomes physically exhausting for many patients, especially older ones or those with other health problems. That massive energy demand is why we fight so hard to save the knee joint whenever biologically and oncologically possible. Preserving the knee makes prosthetic use far more likely and successful.
Now let's talk about handling the tissues during the amputation itself. Myodesis, anchoring the cut muscles to the bone, seems like a detail, but you're saying it's absolutely critical. What happens if we just cut the muscles and let them retract?
If you just transect the muscles and close the skin, those muscles undergo massive atrophy. Studies like the classic work by Jaegers and others show muscles can shrink by 40% to 60% within just a couple of years if they aren't anchored. They just wither away. Myodesis, which is suturing the muscle or its tendon directly to the end of the bone, or sometimes suturing opposing muscle groups together over the bone end, myoplasty, prevents this atrophy. It maintains muscle tension and strength, helps provide dynamic padding over the bone end, and creates a much more stable functional residual limb that can tolerate prosthetic wear comfortably. It's not just a detail, it's imperative for long-term success.
Okay, now consider a different challenge. The patient with severe vascular disease, an ischemic limb. We need good blood supply for healing. Where do we typically find the best perfused tissue for our flap in a below-knee amputation?
In limbs with poor circulation, often due to peripheral artery disease, the blood supply into the anterior compartment over the shin is usually the worst. The tissues on the back and the inner side, the posterior medial aspects, tend to have better collateral blood flow.
So use the tissue from the back.
Exactly. That's why Particularly for transtibial amputations and ischemic limbs, the preferred technique is often the long posterior myocutaneous flap, sometimes called the Burgess technique. You create a longer flap using the wall-vascularized calf muscles and skin from the back and roll it forward to cover the cut end of the tibia. This maximizes the chances of good wound healing in a really challenging vascular situation.
Makes sense. Let's talk about pain after amputation, phantom limb issues. How do we distinguish between just feeling the missing limb, which is common, and actual problematic phantom pain?
That's an important distinction. Almost everyone with an amputation experiences phantom sensations. They feel like the foot or hand is still there, maybe feels itchy or cramped. That's incredibly common, almost universal, and usually not distressing. But true, bothersome phantom limb pain, feeling significant pain in the missing part, is much less frequent. It probably affects less than 10% of amputees to a degree that really impacts their life. When it does occur, treatment needs a multimodal approach, nerve pain medications, maybe mirror therapy, desensitization. It's definitely not just in the patient's head. It's a real neuropathic pain process.
And finally, in the upper extremity, there's been some really exciting progress, particularly with targeted muscle reinnervation, TMR. What is that, and why is it such a big deal?
TMR is truly revolutionary, especially for amputations above the elbow, transhumeral level. Normally, when you cut major nerves during an amputation, their ends can form painful neuromas and the nerve signal just dead ends.
Right.
In TMR, the surgeon carefully identifies those major severed nerves like the median, ulnar, radial nerves and surgically reroutes them. They suture the end of the major nerve into a nearby, smaller, expendable muscle that has lost its original nerve supply.
So you're giving the nerve a new job.
Exactly. You're giving the nerve a new target muscle to grow into. So now, when the patient thinks, close my phantom hand, the signal that used to go down the median nerve now travels to this newly re-innervated target muscle in their residual upper arm, causing it to contract.
And that contraction can be picked up by sensors.
Precisely. Surface electrodes, myoelectric sensors can detect that muscle contraction, which is much stronger and more specific than the tiny signals you get from random muscle firings. This allows for much more intuitive and sophisticated control of advanced prosthetic hands and arms. Instead of just opening and closing the hand, patients can potentially control individual finger movements or wrist rotation just by thinking about it. It's a huge leap forward for upper limb prosthetic function.
All right, let's tackle the final and arguably toughest challenge, orthopedic infection, osteomyelitis. It's not just bone inflammation, it's a real battle. How do we define chronic osteomyelitis, and what's the absolute key surgical target?
So osteomyelitis is, simply put, bone inflammation from an infection. It becomes chronic when the body's defenses and initial treatments fail to clear the bacteria and the infection smolders, leading to bone death. The defining feature, the absolute hallmark of chronic osteomyelitis, is the presence of infected dead bone. We call this dead piece the sequestrum.
The sequestrum, dead bone harboring bacteria.
Exactly. And it's usually sitting within a pocket of chronic inflammation, often surrounded by scar tissue, what we call the compromised soft tissue envelope. Crucially, that sequestrum is avascular. It has no blood supply.
Which means antibiotics taken by mouth or IV can't get to it effectively.
Precisely. Systemic antibiotics can't penetrate that dead bone or the surrounding scar tissue well. That's why surgery is almost always required for chronic osteo. The goal isn't just to drain pus, it's to physically remove the sequestrum, debride all the infected and non-viable tissue around it. You have to get rid of the source.
So surgery's key. How quickly does the clock start ticking when an infection first sets in? Is there a golden period?
There definitely is. The body's own defenses work best early on. We talk about the golden period, usually considered the first 6 hours or so after contamination or the onset of acute infection. Intervention within this window, cleaning the wound, starting antibiotics, gives the best chance of stopping the infection before bacteria really dig in and start killing bone. Prophylactic antibiotics, like given before surgery, can extend this window, but the principle holds. Faster is better. Delay allows acute inflammation to potentially transition into that much harder to treat chronic state with bone death.
Okay, when we're treating osteo, we monitor blood tests like CRP and ESR. Why is the C-reactive protein, the CRP, generally seen as more useful for tracking how the treatment is working compared to the SED rate, the ESR?
They're both markers of inflammation, but they behave differently. CRP is an acute phase reactant. Its level goes up very quickly with inflammation or infection, but importantly, it also comes down very quickly once the source is controlled. Typically, with successful surgery and antibiotics, the CRP level will start dropping significantly within days and should normalize or get close to normal within maybe a week or two.
Okay, so it's responsive. What about ESR?
The ESR, or erythrocyte sedimentation rate, is much more sluggish. It goes up with inflammation too, but it takes much longer to come back down, often weeks or even months after the infection is cleared. So while a high ESR might confirm there was significant inflammation, it's not very helpful for telling you in real time if your treatment today is working. A rapidly falling CRP, on the other hand, is a great sign that you're winning the battle.
That makes sense. So after we do that aggressive surgery, remove the sequestrum, clean everything out, we're often left with a big hole, dead space. We can't just close the skin over that void. What are the main ways we manage that dead space while also trying to deliver antibiotics right where they're needed?
Managing that dead space is absolutely critical to prevent the infection from coming back. There are basically four main strategies we use. One is the open bone grafting technique, often called the Papineau technique. This is usually a staged approach. After debridement, you leave the wound open, pack it, and let healthy granulation tissue, that beefy red tissue rich in blood vessels, grow in from the edges over several weeks. Once you have a healthy bed, you come back and fill the defect with cancellous bone graft. It relies on that healthy granulation tissue being resistant to infection.
Okay, staged, open treatment. What else?
Second, we use antibiotic-impregnated PMMA, which is bone cement. We mix high doses of heat-stable antibiotics, usually tobramycin and vancomycin, into the cement powder before it sets. We can make beads out of it or a solid spacer block to fill the defect. This delivers very high concentrations of antibiotics locally, right in the dead space. The peak release is usually on day 1, but the effective elution really only lasts strongly for about a week or so.
And the downside?
The big downside is that PMMA is non-resorbable. It's a foreign body. So you must go back for a second surgery, typically around 4 to 6 weeks later, to remove the beads or spacer before you do the definitive bone grafting or reconstruction. If you leave it in too long, it can actually become colonized by bacteria itself.
Right, second surgery required. What's option 3?
Option 3 is particularly useful when debriding a long bone, like the tibia or femur, leaves it unstable. We can use an intramedullary antibiotic cement nail. Basically, we fill a chest tube or a specialized mold with antibiotic-laden PMMA around a smaller metal rod, creating a temporary antibiotic-releasing internal fixation device. This provides stability for the bone and delivers local antibiotics. Studies, like those from Tons and Conway, show pretty high success rates for controlling infection in challenging long bone osteomyelitis with this technique. Again, usually requires removal later.
Stability plus antibiotics. Clever. And the fourth option, biodegradable systems.
Yes, this is really the exciting frontier in dead space management. These are biodegradable antibiotic delivery systems. They typically use calcium sulfate or calcium phosphate carriers, which are like plaster mixed with antibiotics again, often vancomycin, tobramycin, or gentamicin. You pack this material into the defect after debridement.
And the big advantage?
The huge advantage is that these carriers resorb completely over time, usually dissolving away by about 8 weeks or so. This means no second surgery is needed just to remove the delivery vehicle. The antibiotics elute out, the carrier dissolves, and hopefully healthy tissue fills in. It dramatically reduces patient morbidity, cost, and the risk associated with another operation.
That sounds like a major step forward.
Yeah.
Okay, last area. Acute septic arthritis, a true joint emergency, especially in kids, right? Why is a septic hip in a baby or toddler, say under 2 years old, considered such a potential catastrophe?
It is one of the absolute top orthopedic emergencies, particularly in that age group, because of the unique blood supply to the top of the femur, the femoral head. In infants and children younger than 2 years, critical blood vessels that supply the growing end of the bone, the epiphysis, actually travel across the growth plate, the physis, within the joint capsule.
Okay.
When the hip joint gets infected, pus builds up rapidly, creating high pressure inside the joint capsule like a tense abscess. This pressure can physically squeeze and compress those fragile blood vessels running across the physis.
Cutting off the blood supply.
Exactly. If that compression isn't relieved immediately by draining the pus, the blood supply can be cut off, leading to osteonecrosis, death of the femoral head, or even epiphyseal separation, where the growth center literally separates. Both are devastating outcomes, leading to permanent deformity, limb length difference, and lifelong arthritis if not treated urgently.
So immediate drainage is absolutely mandatory. How do we typically drain these big joints surgically? What are the standard approaches for the hip and the knee?
For the hip, especially in kids needing open drainage, the anterior approach is often preferred. It gives good visualization of the joint, allows for a thorough washout of the pus, and easy decompression of the capsule. For the knee, simple septic arthritis can often be managed well with arthroscopic irrigation and debridement, using the scope to wash everything out and remove infected synovium.
But what if pus collects in the back of the knee?
Right, pus loves to pool in the back.
Yep.
If we need formal open drainage of the posterior knee compartment, the classic approach is the post-remedial drainage, sometimes called the Kalikian technique. You make an incision on the inner backside of the knee and go through the interval between the semimembranosus tendon and the medial head of the calf muscle, the gastrocnemius, to get right into that posterior space. For the elbow, like the knee, straightforward cases in healthy patients can often be handled effectively and safely with arthroscopic washout.
Wow. Okay, this deep dive has really covered the map, hasn't it? We went from the, almost microscopic precision needed for a perfect primary joint replacement, getting that 45-degree neck angle just right all the way through the high wire act of balancing a total ankle, and then into the biological battlefield of chronic infection and planning a truly functional amputation. It really highlights how success hinges on blending that precise technical skill, the right cuts, the secure myodesis with understanding the materials we use, the implants, the antibiotics.
It really does. And if you try to tie it all together, perhaps the single greatest thread running through all these complex scenarios isn't just the technical challenge, but the patient's own biological resilience. We talked about the surgical skill needed to reconstruct a massive ARI type 3 bone defect, or the strict adherence needed for that 10-pound lifting limit after an elbow replacement. But so often, the factor that ultimately tips the scales between success and failure isn't the complexity of the bone loss or the sophistication of the implant.
It's the patient themselves. It's the host. Exactly. It's the systemic factors we can't easily operate on, the poorly controlled diabetes that impairs wound healing, the ongoing smoking that constricts blood vessels, the chronic malnutrition that prevents tissue building. These things can undermine even the most technically perfect surgery.
That really brings up the most critical and maybe provocative question for anyone in this field or learning it. When does that pursuit of the perfect technical solution get overridden by the patient's fundamental ability or inability to heal? When do we need to maybe adjust our goals, perhaps aim for a stable salvage rather than anatomical perfection because the patient's biology just can't support the ideal fix?
We have to ask that constantly. You see a complex reconstruction plan for a heavy smoker with peripheral vascular disease. The technical plan might be brilliant, but is it biologically realistic? A beautifully executed bone graft won't incorporate if the patient's system can't deliver the oxygen and nutrients it needs. So for you, the listener, the takeaway has to be this. Carry this technical knowledge forward, absolutely, but always layer it within the context of the whole patient. Recognize that the long-term feat of any complex orthopedic procedure is welded not just to skill in the OR, but to that patient's systemic health and biological environment in the weeks and months that follow. That context. It's often the ultimate decider.